Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by Mark Drugs, who specialise in the custom compounding of medications, assuring that the client gets the proper prescriptions for their unique needs and conditions. They work with practitioners, integrating knowledge and treatment of experts to create comprehensive health plans. Visit markdrugs.com or call Roselle 630 529 3400 or Deerfield 847 419 9898. Today I'd like to welcome back Dr. Ginevra Liptan, who, as many of you know, is the lady who has worked so hard and tirelessly with people with fibromyalgia, and she's written a book which I'm sure she'll mention at the end. But welcome back today.
Thank you.
So, what can you tell us about how treatment options have changed for people with fibromyalgia?
Well, I think there's been some pretty positive changes as far as more treatment options for fibromyalgia patients. And then, at least in the U.S., there's been some pretty negative changes with some of the tools being sort of taken out of our pain management toolbox. So that's really the opiates I'm talking about. Mm-hmm. So I'll go into that in a little bit. Let's start with the good. And the positive changes that have happened really are that it's becoming so much more accepted as a diagnosis. So many more physicians and healthcare providers feel comfortable making the diagnosis and starting the initial treatment. It's no longer really something that seems mysterious to the average medical professional. We've really moved very far as the acceptance. There's a lot less stigma around it. And so because of that, like, the treatment options aren't that much different now from a few years ago, but the willingness of healthcare providers to go ahead and try that and start somebody on it and be a little bit more maybe aggressive in diagnosing and treating fibromyalgia, that has really changed. And that's hugely positive. That really is. I mean, it used to be that by the time people came to see me in my clinic, they'd seen, 8 to 10 to 12 different doctors, and they'd kind of been passed around from specialist to specialist, and nobody really wanted to start anything, and nobody really started any medications or, just referred them to physical therapy or counseling. Now people are really getting much more quickly into treatment regimens. So that's hugely positive. Mm-hmm. That really is. Well, and as part of that, I've actually seen LDN being used more frequently. Oh. It used to be like only something that, specialists did, or maybe naturopaths, but I've actually seen at our academic pain center in Portland, the Oregon Health and Sciences University Pain Clinic, they're starting people on LDN now. And it's huge. It's such a surprise to me that the data's been there. It's not like it's new data, right? Mm-hmm. But they've been actually using it. So that's pretty positive.
Wow. Well, having you at the conferences is a big boost as well, people listening to your experience. But I would just like to say that, years ago, the number of people with fibromyalgia contacting me, absolutely heartbroken, crying, that they were told it was all in their head and they just needed antidepressants and the pain was going to go away. And that is just so sad, isn't it? That, you are that desperate and nobody will even listen to you.
Yes, it's so heartbreaking. I mean, it really, really is. And I think, I don't know if this is the same for you, but it seems like we're getting less folks contacting me or my clinic with that particular, people still are struggling to find help, but it seems like they at least know that there are some answers out there, even if they're struggling to get their local provider to to do it. It doesn't seem like the hopelessness is as intense, although certainly there's some other broader societal issues, at least in the U.S., as far as healthcare, that people are really struggling with. But I do feel like there's more of a sense of, there are things out there that can help. There are people that are understanding more about fibromyalgia. There are celebrities now with fibromyalgia. I mean, honestly, Lady Gaga coming out and saying that she has fibromyalgia has been huge. I mean, I had a patient come in and say to me the other day, my daughter thinks I'm really cool now because I have the same disease as Lady Gaga. And I was like, okay, well, this is a little bit of a mind warp, but okay, like, we'll take it, it's kind of shifting the attitude around it. And I think that's filtering down to, I hope, what patients are feeling like, that they're not feeling as alone in their struggle. That's my overall sense.
Well, we need you to contact Lady Gaga and tell her about LDN. That would be cool.
So hard. I have been working so hard. I'm always like, does anybody know Lady Gaga? Because we got to get her on LDN. We got to get her doing some myofascial release. So don't worry, I'm working on it.
I mean, that would just be amazing, wouldn't it? It really would be amazing. Yeah, and get her to come to the conference next year. Yes. I mean,
I know.
You've got somebody there who has such a following, and there are so many young people with fibromyalgia, and it would just revolutionize it. It would take it to
really
outer space, wouldn't it?
Yes, exactly. And if she could donate, $1 million or something, which to her is, probably very little money in the scheme of things, that could actually really revolutionize how we study and treat fibromyalgia.
But
I don't know how it is in the UK, but there's no money.
No, there's no money. There's no money anywhere. No. But even if she didn't want to fund it herself, she would be in a fantastic position to ask for donations. I mean, people would, the money would just come. It would pour in.
Oh, yeah. That's absolutely true. So yes, I'm hereby declaring my intent to bring Lady Gaga to the LDN conference.
Whoa! Okay, I'll even let her come to the speakers only dinner as a VIP.
Oh my gosh, that would be so funny.
It would. Sorry for butting in. Do carry on.
Oh, let's see. I don't remember what I was talking about. I got distracted by Lady Gaga. So the positives are really there, right? But the negatives, at least in the U.S., and I think it's pretty worldwide, is there's really this shift now moving away from using opiates for any reason, whether it's acute pain, whether it's chronic pain. Opiates are sort of the scapegoat now, I think, of, I mean, certainly opiates have their issues, absolutely, and we should be using them only as little as possible. But I feel like for the average fibromyalgia patient, there's so little options in our toolbox that are really accessible to people. For example, cannabis and marijuana-based medicines have great potential. They really do, but they're not accessible to everybody. They're really not medical right now. There's not a lot of good data as far as like how do you actually use it or prescribe it or safety for long-term use. We really don't know that much about it. So it's not really an actual medical option for a lot of people. And then you have opiates, which we know a lot about, and I think can be used very effectively as long as they're not used daily. I think what we've done is sort of say opiates cause addiction problems, so they're all bad, so nobody should ever be on opiates at all. And what I'm trying to kind of I hope that we can get back to more of that middle ground where we say, gosh, opiates have a lot of problems, and we're learning that they really aren't good for long-term daily use. But they do have some benefit for short-term use for flares only. That's how I prescribe them, because fibromyalgia is not a steady state. There are times where people have huge spikes of pain. And during those times, opiates can be hugely effective as a short-term kind of rescue option to help bring things back down. And then you go off of them again. So, maybe taking them 5 days out of the month, 5 of your worst, most intense pain days. I think that that's a very rational and reasonable approach. But for some reason, there's this sort of black and white view about opiates where they're either, good and it's okay for everybody to be on them who has pain, or they're bad and no one should be on them. And I feel like we're sort of missing that gray zone, that middle ground where we say, as long as they're used in this particular way, in this particular dosage fashion, they can be a good option. So it's a little bit, the panic that many of my patients come to me with, where they say, my doctor's going to take me off opiates and I don't know what to do and I don't have any other options. Like people are in this state of huge panic about that. Mm. And I try to reassure them that there are other options. Like LDN can be a great option. You have to taper down on the opiates and then you can add in the LDN. But LDN doesn't work the same way for everybody. And even cannabis, it doesn't work the same way for everybody. Some people get great benefit from CBD. Some people don't, So what I hate is that pain is so hard to treat. Like, let's not take away things from the toolbox. Let's keep adding, but making sure we know what's the right tool for which problem, as opposed to like opiates. Nope, they're bad. Throwing them out of the toolbox, and then what do you have left? So I don't know. I don't know if it's the same in the UK, but there's this huge movement against opiates in the US.
Yep. Only thing I would say is when I was on strong opiates for MS pain, it was a trade-off. I either had to cope with the pain that was unbearable, and I would then feel, okay, I need to take these painkillers. But once I'd taken them, I then had nausea so bad. It was like being travel sick, where, you turned your head and you thought you were going to vomit. Is that normal for strong painkillers? Do doctors give anti-sickness pills or something to cope with that? I've often wondered if, that is normal for people to feel like that.
It is pretty common. That is absolutely a common side effect with the nausea. The other thing that a lot of people complain of with opiates is that it makes them feel very sluggish, like their brain makes them feel kind of woozy or like they're not as mentally sharp. And those side effects are part of why opiates are not perfect tools. If something relieves your pain but makes you so nauseated you feel like you're going to vomit all the time, it hasn't really improved your quality of life very, very much.
No.
So if there are negative side effects from opiates, then that's not the right tool, of course. And I think, the old way is we used to say, okay, well, it's making you nauseous, let's add another medicine on that's, would eliminate some of that side effect. But now they are trying to make better opiates that are more targeted just for the pain receptors and less that would make you nauseous or feel fuzzy or have some cognitive worsening. Mm-hmm. Yeah, just like any medicine, right? They're trying to perfect it. So there are some newer medicines that have less of those side effects. I think we don't necessarily need to throw out the baby with the bathwater. Like, let's say how can we use opiates better until we have better tools, other tools. Mm-hmm. One approach that I've taken is for people that are on opiates and are getting benefit from them, but let's say they have a side effect, you can actually use just like microdoses, ultra low doses of LDN. And for some people, that little bit of antagonist effect at the opiate receptor can help limit side effects. So that's a really interesting way to kind of approach opiate use is, could we, add a little bit of LDN, add a little bit of something like CBD or even THC, something that has some opposite effect, to kind of create a medicine that gives the positive effects without so much of the negatives. Mm-hmm. But of course, that takes a lot of research dollars and a lot of commitment towards studying and treating chronic pain. And it really still does not get the prioritization that it should. Unfortunately, it's really pretty neglected. So, it's not like there's been really good studies looking at, are there ways to mitigate the side effects of opiates by adding, a little bit of LDN or making different forms of opiates. I've anecdotally, I've just experimented, and I've found that for some of my patients, a little bit of LDN, like a very like 0.05 milligrams, like a very small amount, seems to limit or lessen some of the negative side effects from opiates. So, I mean, I think that's worthy of further experimentation. I've also found it helps to limit some of the dependence or tolerance issues. You know, if you've been on high doses of opiates over time, sometimes within a few months, they become less effective. You need higher doses. And then it's this sort of escalating nightmare of needing more and more. And that's when things can get really dangerous with high doses. So I've found that if I can give somebody just a little teeny dose of LDN along with, let's say, their 45 milligrams of oxycodone total in a daytime, that can keep them from needing escalating doses. It can keep that 45 milligrams effective for them for years. Mm-hmm. And that's where I'm like, how can we find that sweet spot until we have other better treatments that can eliminate the need for opiates? Because of course we don't want, there are definitely better ways to treat it, and we need things that have as few side effects and as good safety profiles as we can possibly find. And opiates certainly aren't bad, but they are what we have right now. That's the thing. There's not like a lot of other tools out there. There's really not. That's the unfortunate piece.
Yes. But you are so right. There are pain specialists in the US who are using microdosing of LDN alongside of the opioids, and they're finding that the opioids become far more effective, and they're able to actually reduce the amount of the opioids and increase the microdosing. And sometimes the microdosing can start at 0.001, which must be just a tiny grain of the naltrexone.
No, I can't imagine compounding.
Yeah, and then as they increase the ultra low dose very slowly, because the opioid becomes more effective, they then start to decrease the amount of the opioid, and some of them get them off the opioids altogether and on the LDN, and find that the LDN was working more effectively than the opioids were, and getting them off that way of titrating it down whilst titrating the LDN up, it eliminated all side effects and withdrawals, I'm told.
I bet, yes, there'd be so much less withdrawal. I think that is a really sensible and rational approach that's like replacing saying, opiates are not a great tool. Let's titrate you off this way, see if LDN at microdoses can help it be more effective, ease withdrawal symptoms, and then once able to get off the opiates, then going up on the LDN to actually address kind of the underlying issues that are generating the pain. That approach makes so much sense to me, but there's not really a widespread acceptance that is a way to do it, and
there are
people
doctors
just yank people off opiates.
Exactly. But there are doctors who are trying to get papers written and case studies things published. So hopefully that will be out there eventually, and people will be able to do that. But alongside of the opioids, talking about the tools in your toolbox, are you using other things for pain, gabapentin or Lyrica or whatever?
Yeah, I run the gamut. I use things like gabapentin and Lyrica to kind of calm down the angry, overactive nerve signaling. I use muscle relaxants. For some people, muscle relaxants like baclofen can be really helpful for both reducing pain and improving sleep quality. And in fibromyalgia, sleep is the area that I really work on the most. If we can get people getting better quality, more deep sleep, their pain levels will automatically reduce, because sleep deprivation itself is part of what generates a lot of the fatigue and pain and inflammation of fibromyalgia. So I use a lot of alternative pain treatments, but I'm usually using ones that also have the added benefit of improving sleep. And gabapentin and Lyrica and baclofen all have that capacity. So I'm usually trying to get kind of a two for one benefit. Some of the muscle relaxants, like cyclobenzaprine or tizanidine, also can do that, relax the muscle tension and help the brain get into deep sleep. And also that gives some pain relief. And more recently, I've been experimenting with CBD, the cannabidiol component of cannabis, because there is a little bit of kind of nerve calming effects, a little bit of muscle relaxant effects with CBD. It has an anti-inflammatory effect for some folks, and it can, for some people, really improve sleep quality. Now, it's a mild effect on all those, but kind of cumulatively, I've seen CBD to be a helpful additive. So I often have people on more than one thing in the toolbox. Like I'm trying to both reduce the painful nerve signaling, let's say with gabapentin, but I'm also trying to help people soften their muscle tightness with maybe something like a muscle relaxant. And CBD is kind of interesting because it can do a little bit of all of those things. Some people with fibromyalgia also really benefit from anti-inflammatories like celecoxib, things like that, COX-2 inhibitors. I have a few fibromyalgia patients that get great benefit from anti-inflammatories. Now, not everybody, but for some people, that's something that we add into their toolbox. So I feel like with fibromyalgia, we have to have as big a toolbox as we can, and then within that, try and find what works best for each individual person. And that might look different for each person, right? But you have to kind of know all the toolbox options. And that was my motivation for writing the Fibro Manual, is that I wanted people to kind of know every possible option out there that they could consider, talk with their doctor about, some things they could try on their own, to find that right combination that really helps ease their symptoms, because there is not, unfortunately, that one magic bullet that works for everybody. And sometimes it's a combination of things. I mean, I have people that use low-dose Naltrexone plus maybe a different type of anti-inflammatory, or LDN plus gabapentin. It's not just kind of one thing. It seems like we have to approach the brain from multiple different pathways, multiple angles to really kind of overwhelm and push it down into a more a state that's more conducive to kind of less pain, less inflammation. So I like the combination of CBD and LDN. I think that, and I know you've talked about that in some of the providers that you've interviewed. There's a lot of folks using that, looking at that combination, and I think that's kind of an exciting area of hopefully future research. Do you know is anybody like published anything or study? I've looked some, and I haven't been able to find anything specifically published, but I thought maybe you might know about some stuff people are working on.
Professor Angus Dalgleish, you met him last year in Portland at the conference.
Yes.
He's using in his cancer patients LDN and CBD, and I think he's trying to get enough patients together to write something and to get published. But he's finding great results using both together. But just getting back to your patients, we have found that fibromyalgia patients on the whole are generally very ultra sensitive to all drugs. LDN is still a drug, even though it's in a very low dose. And sometimes we've found they have that group of patients has to start on quite a low dose of LDN. If not, it creates more pain rather than helping initially. What dose do you normally start your patients on?
So I completely have found the same thing, that this patient population tends to be more sensitive. I used to just do the regular kind of 1.5 milligram for 2 weeks and 3 milligrams for 2 weeks and 4.5 ongoing. What I found is that for many of my patients, that was too much and it was too fast. So I've more recently been starting with 1 milligram, and I'll have people do that for a month, and then 2 milligrams for a month, and then 3 milligrams for a month. And it seems like for fibromyalgia, honestly, that 3 milligrams seems to be enough. I don't always need to get somebody up to that 4.5 milligrams. And I've just seen that a lot of my folks don't tolerate the 4.5 milligram dose. It seems to maybe generate more sleep disturbance or more anxiety. That's the biggest issue I've had with particularly, I think, in the fibromyalgia population. I know that anxiety is a side effect that can occur with LDN, but I've seen it much more frequently in my patient group than kind of what the literature reports as far as the frequency. And I think that maybe has something to do with kind of the underlying fight or flight response overactivation that's going on in fibromyalgia. So I have started with 1 milligram and then a much slower, give it a month between dosage increases. Mm-hmm. And that seems to work better. I've had more success with that. I've had a few people that I started with 0.5, people that I know really have a history of not tolerating things very well at all. Mm-hmm. I've started with 0.5, and I have some folks that even with 0.5, they get some side effects, but they actually start to see a little benefit too. So I have some people I just leave on that tiny, tiny dose. And I know that's different than kind of what's typically done, but I'm curious to see if other providers have had the same experience with fibromyalgia patients, that maybe we need a lower dose than what we typically think of.
And if people are looking online and find the optimal dose that any patient is meant to take is 4.5, well, and then people contact me, I was doing really well on 3, and every time I keep trying to go up to 4.5, and I've tried over the last year, I don't feel as well. They find it really difficult to believe that if 3 made you feel really good, why try and get up to 4.5? 3 is the dose for you. But I'm told I will get better benefits at 4.5. Well, not if it makes you feel ill, and you're doing so well on 3. Let's call it 3 for you. But it is finding that right dose for the patient. LDN isn't like paracetamol, take 2 4 times a day and off you go. There are some people, as you were saying, a lower dose is best. Some people find, 1.5 is the dose for them. It works great. Any higher, they don't feel as good. And people say to me, how will I know if it's not working? That it's the wrong dose for me. Well, it depends on what condition you've got, what the side effects that you've suffered, or the condition. You don't know until you try it, but it's just a case of, if you work up slowly, you can see how you felt prior to putting it up. And if you don't feel as good, whatever as good means for you, well, then drop the dose.
Go back down.
Exactly. So I'm pleased you said that.
I do a lot of trying to reassure patients that, 4.5 milligrams is not the magic dose for everybody. We have to find where it's optimum for them. Yep. I think the challenge is, because fibromyalgia is it's not like there's like a lab value that you can look at and say, yes, at this point, this is when my lab value started to improve. What we're looking at is really subjective symptoms of pain reduction, fatigue reduction, sleep improvement. So what I found is that it really can be helpful to have people, either keep a diary, track their symptoms, use something like the LDN symptom tracker, because otherwise it can be really hard to figure out, okay, well, when I increased up to 3 milligrams, my symptoms got worse, but also I was having a lot of stress, and I changed my diet right around that time. And, there's so many variables going on at any one point that it can make it very challenging for somebody to really objectively look and see, okay, yes, I felt good at this dose, but then when I went up, then I had this problem. So I try to encourage people particularly when we're starting LDN, to really track their symptoms so that we can kind of use that information to help them find that sweet spot, that perfect dosage for them. Mm-hmm. And I have people that can tell the difference. I have one patient that she's at 0.25 milligrams, and when we go up to like 0.3, she notices worsening of symptoms. If she's at 0.2, she doesn't get benefit. Literally, she is that sensitive to 0.25. That is, but we've only been able to fine tune it to that level because she's so good at tracking her symptoms, and because she's so diligent about it. Otherwise, we're sort of just like, well, now you're feeling worse, but is it because of X or Y or Z or because, it can be kind of crazy making. So,
yeah. Well, we've actually run out of time, but I would like you briefly to tell potential patients how they can contact you and where they can purchase your book.
Sure. Thank you so much for having me. If they want to know more about me in general and kind of the work I'm doing, Dr. Liptan, Liptan, is the best place to go, and they can purchase my book either there or on Amazon.
Well, once again, thank you very much for being our guest, and I'd love to have you back next year, and we will talk about what you have been doing in between
Sounds great.
time.
Great. And
Okay.
Thank you so much for having me. Okay.
Thank
Bye-bye.
you. Bye-bye.
Bye.
This show is sponsored by Mark Drugs, who specialise in the custom compounding of medications, assuring that the client gets the proper prescriptions for their unique needs and conditions. They work with practitioners, integrating knowledge and treatment of experts to create comprehensive health plans. Visit markdrugs.com or call Roselle 630 529 3400 or Deerfield 847 419 9898. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.